Okay, good morning, everybody. I know it's early, but I appreciate your effort to showing up to our sessions. The second semi-live session today is with Dr. Badani from Mount Sinai, New York City, and he'll be talking about robotic partial nephrectomy standardization and high complexity.
Okay, good morning, everybody. Thank you for being here on this Friday. I'm honored to be here to talk to you about robotic partial nephrectomy. Let's play. Shake the mouse. Shake the mouse. Got it. Okay, so I was asked to talk about challenging cases. And I think there are a lot of things that tell us if something is challenging. Oops. Yeah. Sorry. So challenging can come in a lot of different ways, right? Tumor size, shape, depth, complexity score, whether you use renal score or Padua, solitary kidney, prior abdominal surgery, existing, chronic kidney disease, et cetera, et cetera. A big one being, of course, visceral fat. So complexity comes in a lot of shapes and sizes. So we can pick a lot of these things, but that would be a long time to talk about. So I'm going to focus on just a couple of them. So first, just talking a little bit about, my overall experience. And so, we have a very, very specific data collection process because we want to see how we're doing and how we continue to improve. And that's when we introduce new technology, change techniques, etc. But overarchingly, the goal when I started at Mount Sinai was to make sure that we were doing partial nephrectomy at the highest level. And so anyone who was an appropriate candidate for a partial nephrectomy was getting one. And so what I'm seeing here is, somewhere around 20, this was 2,100. We're at about 2,800 cases now. About 85% over the last year of all comers, everyone who walked in the door got a partial nephrectomy over radical. And I think that's about the right number. And I've spoken to some of my colleagues, many of whom are here, about their practices, and the number is similar. It's low to high 80%, which means that appropriately, if you're a heavy partial nephrectomy program, about 15% of your patients get a radical because of the tumor, the tumor burden, the tumor disease. And so I think this is where we need to land if we're really trying to spare kidneys with this operation. The other thing I want to point out, and this was seen in the robotic prostatectomy literature, is that the learning curve continues on, right? And there are a lot of nuances to learning curve. But the bottom line is, if you look at the pink, right, that's comparing last calendar year with blue, which is the whole experience. And you see that even after, a couple thousand of these procedures, we're seeing an improvement in outcomes nonetheless. Readmission rates, overall complications, major complications. And so that will continue to get better and better. Here's just a quick, distribution of the histology. Length of stay, everyone except for these dots are individual patients, stay 1 night. Ischemia time based on complexity score, low, moderate, high. Same thing, we don't see a difference in that. And so whether you're doing an easy tumor or a hard tumor, we have a similar expectation of outcome. And I think that's a point I want to make next, which is when you standardize your approach to how you treat this, then the outcomes will follow. Operative time, EBL, length of stay, complication rate. We're not seeing a difference. This is a meta-analysis comparing open, lap, and robotic, and you see the improvement. So here, this is what I call the tumor complexity spectrum, right? On the left, you have low complexity tumors. In the middle, you have intermediate complexity tumors, and on the right, high complexity tumors. And so we used to think about these patients very differently, right? If you had an easy tumor or an exophytic tumor, then you said, oh yeah, for sure, I should be able to do a partial, and you go home at X number of days, and you'll have X number of risk of complications. And then you had a high complexity tumor, and you'd say to yourself, well, I don't know, maybe we won't do a partial, maybe you'll have a bleed, maybe you'll have a urine leak, we're going to have to do this, that, and the other. But I think what robotic surgery has done is a very unique thing unbeknownst to us. It's a way of standardizing this operation. It's a piece of technology, a platform that has changed the way that we treat this disease. Because now, whether you're a high complexity tumor or a low complexity tumor, our outcome expectation is the same. I don't have a different talk track for these patients in the office anymore. They should benefit from the same postoperative pathway that someone with an easy tumor benefits from. And that's what we're seeing here. Yeah, there's a little bit of differences when you look at op time, but the magnitude of that difference is very small, 20 minutes, 2 minutes of ischemia time difference. And so we've what I call standardized across this complexity spectrum. Now, okay. So same thing, low tumor complexity, intermediate tumor complexity, high tumor complexity, same outcome. So standardization is important, followed by experience. So what I'm going to show you now is this concept of treating the endophytic tumors, because again, I was asked to talk about complex tumors, and what I'm doing is I'm weaving a story saying that we started with easy, we went medium, we got to hard, and now we're at a point where we're offering the same outcome expectation to patients. So out of all those challenging variables, I picked endophytic. And again, there are a lot of different challenges, and you'll see later today in the live surgery, there's going to be significant challenges in the partial nephrectomy. But I'll leave that to be a surprise at the time. But this is a very endophytic tumor, so high complexity score, challenging case. And so my way of approaching these, and there are different ways of doing it, but my way of approaching these is something that I call a skull cap. And what that means is instead of going through the hilum or instead of trying to dig into the cortex to get to it, I remove the entire cap of cortex overlying the tumor itself. And you'll see why that's going to be highly beneficial in these cases. And again, I've tried it many different ways, and this has become our approach for dealing with these purely endophytic intracortical, and this one being underneath the cortex issues. And intraoperative ultrasound is paramount for these types of operations. It's entirely an image-guided operation at this point. You are essentially using imaging to decide all the steps of what you're doing until you actually get to the tumor. And so if you're not good at intraoperative ultrasound, you need to become good. And how do you become good at intraoperative ultrasound? You just keep doing it, right? And so I advocate, and I've said this many times to everyone who asks, even in the easy tumors, use it, get good at it, see the interface, understand the anatomy, understand the nuances of how to look at these tumors, because when it's hard, you're going to be glad that you did all those things. If you're just using it in these difficult cases, I think you're going to find it very difficult and not be as comfortable. Because these tumors, if you angle a little bit off, right, think about it. You're starting at the kidney here and the tumor is here. If your angle is a little bit off, you're going to miss it completely. And I've seen that happen many times. And so the better you are at this, the better this operation will go. And so you see how much time we spend on ultrasound because, A, I don't want to miss it. And once you make a hole in the kidney and you've missed your target, it's really not a pleasant place to be. So take your time, do the ultrasound. And I'm going to... Right, so we clamp, done my ultrasound, clamping artery. Typically in these very deep tumors, I do clamp the vein to just prevent venous back bleeding. I understand it's not necessary, but I definitely see a better, cleaner base. So now, what we want to do is get into our cortex and then peel it away. And remember, this is all based on the 3D conformation you made in your head with ultrasound, right? You don't see it on the surface. You don't see where you're going. You just see kidney. I mean, this is just normal kidney, right? Basically, what I'm doing is blindly cutting the cortex off. But I know where the tumor is based on ultrasound. So this is the skull cap, right? I've completely taken off the cortex overlying the area of the tumor. I still don't see the tumor, although I'm starting to see it. But I'm going to take this cap of cortex off. The other thing that's interesting is we did a series of studies looking at the viability of this tissue if you left it in place. You left it as a flap, and you sewed it back on. And of course, universally, that tissue is ischemic. It is not functional cortex. And so preserving it doesn't provide any functional benefit anyways. But what we are able to do is have beautiful then access to this very deep tumor, right? And you see this here. And so now we have unencumbered access to it. We can get to it. We don't have the kidney in front of us that's coming up. We don't have the kidney that's in our way. And so there's no obstacles. And this isn't just important for excision of the tumor, which of course you want to excise it cleanly without causing a rupture in the capsule, but you have to reconstruct the kidney. And these deep reconstructions, if you're working in a hole, very hard to manage if you miss a bleeder or there's an arterial bleed once you unclamp, etc. So here the rest of the skull cap is being removed. Tumor is free. No, tumor's not free yet.
Are you using a Cartier in your left hand there?
This is a forced bipolar.
Okay, forced bipolar.
Yeah, this is a forced bipolar. And then, yeah, we have a protocol where we bank our tumors and we bank normal kidney as well. That's what that was. And now the tumor's out. And now look at the access to this very deep hole, right? We have a view of it. So reconstructing this is much nicer and certainly more precise than if I was working in a hole with cortex over me. And you see the collecting system, you see the base, you see the venous sinuses, et cetera, and you can reconstruct this nicely.
So this is like a 3.0 V-lock?
This is a 3.0 V-lock. Yep, exactly. And I put a pledget on the end. That's my assistant doing it for me because I must be, I don't know, checking my email, so I'm not sure what I'm doing at that moment. But reconstruction, is important. And again, as you know, the risk of pseudoaneurysm, delayed bleed, and urine leak is going to be on these missed arteries in these deep tumors. But now this doesn't look deep. Now the kidney looks like it's been pretty beat up. It's filleted open. But functionally, and we've done all the functional, a lot of functional studies, functionally we don't see a difference as well when we do these deep tumors versus the low complexity score tumors in terms of GFR change over 6 months. And now we have some 12-month data. So I think the point here is you take your time, cut the tumor out with good view, open up the skull cap, and then you reconstruct with a nice view. And then once I'm done with the inner layer, I will early unclamp. And in these deep tumors, very important to do this, right? If you early unclamp and you see an arterial bleeder, you can go get it. But if you close the cortex first, that's when you don't see it, and that's when you have a pseudoaneurysm. So,
ever had an issue with that clip being in the bed like that in this skull cap technique? Because it is going to be pretty close to the collecting system, obviously.
Yeah, so what I do, just so you know, if I run out, the only reason I put a clip there is because I ran out of stitch. So if I put a clip in the bed, then my next stitch, I oversew it. I incorporate it into the stitch. And if you incorporate it into the stitch, I haven't seen it erode into the collecting system. But yeah, if you leave it there by itself, I have seen erosion into the collecting system.
So you're almost fixing it into place so it can't move.
Yeah. So I sew it. I sew it into place. I mean, I don't do it often to leave it in the bed. I really try not to, but sometimes in these big defects, you just end up running out of the length of the stitch. And then the other thing is this is indocyanine green. Again, in these very central tumors, sometimes you can compromise the blood supply severely. Much of the kidney is ischemic and you don't realize it. And so one of the uses of Firefly in this situation is just to make sure what you have left is healthy perfused kidney. And you can see that here. And that's kind of my primary use of ICG during partial now. I don't use it for a lot of the advanced clamping techniques. Or margins. People are using it to look at margins because clear cell does not pick up ICG. And this is a hemostatic agent. But ICG to look at perfusion of the kidney is very nice. Yep. So I think, here's another case, very similar, solitary kidney, right? Single kidney, central endophytic tumor, and that's where these things really pay off when you have a standardized way of doing this operation. Because this lady walked into my clinic 5, 6, 7, 8 years ago. I'd be really nervous about this, right? Big 5 centimeter central tumor, solitary kidney. Boy, that's a night I'm not going to sleep coming into this. But because we kind of do this all the same way, and listen, my OR team, my assistants, my residents, everybody kind of knows what these steps are going to be and what to expect. So everyone is on the same page as well. You see this tumor, very deep, very central. And, I think it's important, and there are many ways to do this. So obviously what I'm suggesting to you is pick one way that works for you and do it that way until you get very good at it. But for me, I've done it all the different ways. And those ways are, you can do it transhilar if it's a central tumor. You can go in from the hilum and get to it. You can do a radial nephrometry, which is what we're doing here. But then I take it one step further and excise the cortex. This is the skull cap. Ben, any thoughts on your end on how you approach these tumors?
Yeah, so I think the ultrasound is key, obviously, and before we had these drop-in probes, you had to rely on this laparoscopic probe, and often the angle would be such that you wouldn't know exactly where to cut, and then you'd kind of have to readjust your cut once you got closer to the sinus. But I think that with the skull cap, I mean, obviously putting on a non perfused piece of cortex on top isn't going to help you.
Right.
But at the same time, if you need to kind of reconnoiter and say, okay, I'm slightly off with my ultrasound, that I need to cut a little bit differently to get it out, then you still can do that and not, burn your bridges.
Yeah, one of the things, that's a good point. One of the things is just bringing the ultrasound in and out. So many times what I've done is I've done my initial radial nephrometry, and if you don't see the tumor, which is, I'm seeing it here because it's a big tumor, but if you don't see it, once you've taken the cortex off, you put the ultrasound back in and make sure the angle that you're going at is correct. And I'll do that a lot. I'll take the ultrasound and do my initial, come out, make a cut, take the cortex, put the ultrasound back in, put the ultrasound back in, just to use it as a guide. And we've become far more image guided in the way we do this than we have been in the past. And I think it's good, right? I mean, obviously, it's going to continue to improve, and how we're imaging is going to continue to improve. But this is the way to do it. And we're urologists. We're comfortable with imaging, but we just aren't comfortable with intraoperative imaging unless we're doing it ourselves. And that's the only place you're really getting that experience.
And I think if you run into a situation that's tough, excuse me, you can always have your radiologist come by. But you're right. Just keep doing it and keep doing it. I noticed you used the forced bipolar in that other case, but here it's just a progress. Was there a reason for that?
Yeah, probably because what happens sometimes is the forced bipolar, if it's misused, the jaws are a little bit off. And then, so when they put the instrument in and the jaws are off, say, okay, this isn't going to work. So then I just switch to the progress. Because I don't switch instruments much. The only instrument change I make is this scissor becomes a needle driver in the right hand. That's it. And I don't want to change instruments a lot. And with the regular bipolars, it's hard to open and close the bulldogs or you do the ultrasound. And obviously in these endophytic tumors, you need a lot of that movement of ultrasound. So the forced bipolar holds those things nicely, and so does the progress. But probably that's what happened here, is that the forced bipolar was misaligned, I guess is the best word to say.
I thought you were going to tell me some trade secret.
No. That, as I always say, the GYNs used the forced bipolar and broke it before, the case before. So, so yeah, the other thing I'm going to show you, same as the last case, is you're deep in a hole, but you have a good view of it, right? You have an unencumbered view of what's inside this kidney, and you're putting it together very precisely, and that's what prevents problems later. And so I really do encourage you all to make sure that that exposure by cutting that cortex off is nice. See here, I ran out of stitch there too. So these are all V-locks, 3O V-locks, and that's how I do my inner layer. In this case, you see I use the skull cap as a handle with the fourth arm, so it holds the back of the kidney up, or the front of the kidney up, so I can see inside, and then I'll excise it at the very end.
Oh, that's really nice.
Yeah, and what that also does many times is it keeps your fourth arm out of the way.
Yep.
So
Exposure is great too.
yeah, so you're not clashing. Early unclamping, as I showed you, and you'll get the theme. It's similar steps. It's a similar way of doing it each time we do it.
I think clamping the vein here is important, just like you mentioned. Oh, there's a little bleeder there, so you can take care of it now.
Yeah, so now you see it. You see a little bleeder happening. And so there are two ways of dealing with it. If it's close to the cortical edge, then you can, of course, use the outer layer sutures to get it. But if it's more central, it's just nice to put a stitch in and take care of it. And even though I had a good view, when you have a large surface area deep in the kidney, invariably there's going to be a bleeder or two that just make it seem to escape. You see that clip in the middle? You see the stitch running over it? That's just over sewing the clip. That was your question to me?
Yes.
Yeah.
Yes, good point.
Yeah, so again, Dr. Chung's point was right. If you put a clip in the bed, it can erode. So my way of going around that is to make sure I sew it in place.
But I think here also, you're not going to, I mean, you could, but you're less likely to miss a bleeder deep inside, which will, bring this patient back to the IR suite for angio. But she's got a solitary kidney, so that could box her kidneys. So,
Yeah.
I mean, it's...
Yeah. And I think one of the other points, too, to make, and you bring this up, is, a little extra ischemia time is significantly gentler to a solitary kidney than going to IR and getting contrast and being embolized. And so I definitely, although time does matter in these solitary kidney situations, I don't really count the clock. I don't ask to be told every minute or every 5 minutes. I don't actually want to know. And you see there's good perfusion, same utilization of ICG. But I don't actually want to know the minute-to-minute play on this because I really do want to take my time and do it. And we don't see a lot of, and here's the perfusion of that flap just to show you. The upper pole's good, flap is dead, right? No perfusion of this, just proof of concept, and then I'll cut it off. But the point is that, you really don't need to count every single minute when you're trying to preserve a solitary kidney. And although time does matter, it matters much less than a complication and requiring embolization or reoperation later. So really, don't let that get to you. Take your time, do it, and be clean about it.
I think that's an extremely important point. Rather take another 5 minutes than, end up in the IR suite and, the patient's already close to dialysis at that point if they're bleeding out, so...
Yep. I'm going to go past this one a little bit. And I'm just going to show you a couple complex situations. So I think you got the concept of this skull cap. And I have several videos also online, and I can share those links with you. And so, in the end, of course, complications happen if you do difficult surgery. Here's my fellow. He wanted me to include this because he really felt bad, but you had a side, right? This was a week ago or maybe 2 weeks ago. And what he did right, what did he do there that was correct? He grabbed it right away, right? Injury, grabbed it right away. Now this is minor. This is not a big deal. We can, fix this, and we're going to fix this. But the learning point, and this was for a radical nephrectomy, of course. I'm not doing a partial here. But the learning point here is if you have a bleeder and you get into it, you have about a second, half of a second to grab it when you still see it before it becomes a pool of blood. And so the instinct, even in the trainee's mind right now, was let me grab it right away. And definitely I commended him on doing that and doing that the right way. So here we're just stapling underneath the hole or incorporating the hole. So that way we manage that little bleeder. But if this was a partial, you would have to put a proline and just do a figure of 8 and oversew it, et cetera, et cetera. Here, let's see. Right, this is a bit of a different one. So dissecting towards the hilum, and lower pole renal artery, right? Different fellow, So I'm not going to blame the same person again. But it's good, right? You didn't see it, and he noticed it before it went through. So what I do is, in these situations, I put a bulldog on, and then we can repair it, even though it's not through and through. But when you weaken the adventitia of the arteries, it will aneurysmally dilate, and then you can have a rupture. So this is a Prolene suture, and reconstructed. And again, you can't be afraid of fixing veins and arteries. We do it all the time, especially when we're doing selective clamping or dissecting out the branches of the hilum to do selective clamping. You run the risk of injuring some of these smaller arteries and veins, and so we fix them. And certainly you could sacrifice a lower pole artery. Of course, you'll have end organ ischemia of that area, but I think fixing it's the right move, and so that's what we did here. And then we continue on with our operation and finish the partial nephrectomy. So here's a redo partial after an open partial. And so now I'm doing a salvage radical nephrectomy in a very scarred environment. So you see how thick this scar is around the hilum. It's just thick scar. The vein looks very nice. I was able to delineate that, but this is just thick scar. And so as we're doing this, and tend to do a lot of salvage kidney surgeries, which robotics is a nice approach for the salvage operations. But you guys gotta work your way through the scar. And so this is one of those situations where you don't know where the artery is. You can't see it very well. Certainly the tissue is not giving you anything. And there, right? So we got it. So what happened first? Grab it right away, right? Grab it right away. And now you can take a second to think about it. Now, we did the wrong things here. The idea was, let's clip it. Well, let me tell you, clipping an artery that's embedded in scar, that's a bad idea. So now we have worse bleeding, right? But the point is, it's manageable, right? So I'm holding it, so it's slowed it down. It's still going. And then idea number 2, let's try it again. No, don't try it again. You learn from me. Don't do this. Okay?
Maybe a titanium clip here?
And so, this is just pure scar, right? Nothing, no clip is going to work. And then the thought was, let's put a stapler. And stapler's not going to work either. You have nowhere to put it. And so, of course, one of the beautiful things you can do is sew one-handed, right? The robot allows you to do it. And so I'm holding the bleeder with my left hand, and then I can just oversew the base of this with the suture. And I have a pledget lapper tie on the end, so I don't have to tie it and let go. Right? And just oversew the bleeder and take care of this. And so this is just an example of essentially troubleshooting, problem solving, dealing with bleeding and hemorrhagic issues with the robot. You really do have more control than I think most people think when you're in these situations. You don't panic. You don't immediately convert to open, because converting to open when you have a bleeder like that is not a good thing either. And so you control it, hold it, grab it, solve the problem robotic. And then, this was a salvage radical, so we're gonna finish the operation now.
So that was like a 2.0 PDS or something?
This was a Prolene. I'm gonna guess 3.0. It could have been a 2.0. I don't know. Yeah, 2.0, 3.0. And that's a rescue stitch. Yep. And this is another concept, right? And we saw Dr. Porter yesterday in the RPLND talk about his rescue suture. And essentially what a rescue suture is it's this. It's the oh no moments where you get into something and then you have to deal with it. And you have this, what I have is usually a 3.0 Prolene prepared in these challenging situations, so that if I need it, they don't have to go find it and cut it to size and all of that. It's ready to go. And that's what we call a rescue suture. And in RPLNDs and redo kidneys, salvage kidneys, IVC thrombuses, et cetera, I'll have a 3.0 Prolene rescue suture available. So now when I'm on both sides of this artery, I can staple it nicely and finish the operation. Oh.
I think the key, though, is you knew the cava was below where you were dissecting the artery, right, the whole time?
Yes, cava you could see. Yep,
So.
exactly. Yep, there's your titanium clip then.
Grasping at straws at that
After,
point.
just in case. It's a little extra. But anyhow, we have a pretty large salvage experience we just published, and I really do think robotics is a better approach for those salvage situations than open. So with that, I'm going to leave you. Thank you for your time. Enjoy the rest of the conference today. Hope you tune into the cases later.
I think I've asked all my questions of Dr. Badani. Does anyone from the audience have anything? Otherwise, we'll continue with the program for the next semi-live. Okay, great. Thanks so much.
Thanks.